Hello everyone, my name is Frank Carvajal and I'm talking about with Cabozantinib in patients with advanced and progressive hepatocarcinoma. Introduction. The systemic treatment options available for most cases are limited. The vascular endothelial growth factor, or VEGF pathway, is an established therapeutic target in hepatocellular carcinoma, with the clinical benefit for target this pathway has been modest, which suggests that inhibition of additional signals pathway might improve efficacy. MET and AHL play diverse roles in tumor biology, including the promotion of the epithelial to mesenchymal transition, invasion, and metastasis. Both kidneys are implicated in resistance to angiogenic therapy. High expression of MET or AHL may be associated with poor prognosis in patients with hepatocellular carcinoma. For cabozantinib is an inhibitor of tyrosine kinase, including the VEGF receptor type 1, 2, and 3, the MET, and the AXL. And this in, inhibit tumor growth in murine models of hepatocarcinoma.
Hello. We're going to talk a bit about hepatocellular carcinoma, commonly known as HCC. HCC is the primary cancer of the liver. It's the third most common form of cancer in the world and one of the leading causes of cancer death. The liver is the largest organ in the body, and it's responsible for many important metabolic functions. It cleans toxins from the blood, detoxifies chemicals and metabolizes drugs, which leads to the secretion of bile, and it maintains the right level of blood sugar in your body. Now, you may be wondering what actually causes HCC. HCC develops from underlying chronic liver disease and cirrhosis. Cirrhosis is chronic inflammation of the liver, which causes small clusters of abnormal cells, called nodules, to develop. An inflamed nodular liver is an ideal environment for malignant, or cancerous, tumors to grow. When one nodule appears, trouble is usually not far behind. The most common cause of cirrhosis and hepatocellular carcinoma is hepatitis C. However, increasingly more people with fatty liver disease and fibrosis are also developing HCC. Basically, any serious or chronic inflammation of the liver can cause these malignant tumors to develop. There are less common causes of HCC to consider too, such as frequent alcohol abuse, type 2 diabetes or inherited metabolic diseases, exposure to toxic chemicals and water contamination, and sustained use of tobacco. This is where HCC can get especially tricky. Symptoms often don't appear in the early stages of HCC. In fact, most people don't exhibit symptoms until the disease has reached its later stages. So if any of these factors put you at a higher risk, don't wait to talk to your doctor. And because your liver works so many critical jobs, signs of trouble can vary and may show up as common or seemingly minor symptoms. But blood tests, imaging, and sampling of liver tissues can catch abnormalities early on, long before symptoms appear, when liver cancer is the most treatable and there's a chance for a cure. The number of people diagnosed with primary liver cancer is growing. In fact, the number has been growing steadily since the 1980s. Knowing your individual risk for HCC and taking preventative measures is vitally important. So who's at risk for HCC? Well, this depends on a number of primary factors, including sex, age, and ethnicity. To start, HCC is much more common in men than women. On average, people are in their early 60s when first diagnosed. and more than 95% of people with liver cancer are over the age of 45. While hepatitis C is the most common cause of HCC overall, it's not necessarily the most common across the globe. In Asia and sub-Saharan Africa, the leading cause of HCC is hepatitis B. Individual risk based on ethnicity breaks down even further. Asian Americans and Pacific Islanders have the highest rates of liver cancer. African Americans and whites the lowest rates. Symptoms of HCC don't often appear until the disease has advanced, and it's important to know what the symptoms are. Unexplained weight loss or loss of appetite, feeling very full after eating very little, nausea or vomiting, pain in the abdomen or near the right shoulder blade, swelling or fluid buildup in the abdomen, itching, yellowing of the skin and eyes or jaundice, fever, enlarged veins on the belly that are visible through the skin, abnormal bruising or bleeding. The only way to know is by talking to your doctor and knowing your risk. To learn more about HCC and comprehensive treatment, visit our website or call 877-LIVER-MD.
Application in medicine. Results. At the second planned interim analysis, the trial showed significantly longer overall survival with Cabozantinib than with placebo. Median overall survival was 10.2 months with Cabozantinib and 8.0 months with placebo, with 95% confidence interval. Median progression-free survival was 5.2 months with Cabozantinib and 1.9 months with placebo, with confidence interval with 95%, and the objective response rates were 4% and less than 1% respectively. Grade 3 or 4 adverse events occurred in 68% of patients in the Cabozantinib group, and these adverse events occur in 36% in placebo group. The most common high-grade events were palmar-plantar erythrodysesthesia with 70% with Cabozantinib versus 0% with placebo. The other high-grade event is hypertension, increased aspartate aminotransferase level, fatigue, and diarrhea. This is the graphic of the study, Kaplan-Meier analysis.
Hepatocellular carcinoma, or HCC, is another cancer that requires multiphasic imaging. But unlike other cancers, in many cases, HCC can be diagnosed based on imaging features alone. The liver receives most of its blood supply from the portal vein. HCC, on the other hand, gets most of its blood supply from the hepatic artery. This means that the HCC will have more arterial phase enhancement from the hepatic artery when compared to the rest of the liver, since the normal liver is getting more blood supply from the portal system. Conversely, HCC will look darker than the rest of the liver during the portal venous phase because at this point the liver has received contrast mixed blood from the portal vein and the arterial flow in the HCC has washed out. Therefore, when looking at the liver using arterial phase imaging, HCC will often appear as a rounded mass that is enhancing more or brighter compared to the background liver. In comparison, during portal venous and other delayed phases, HCC will enhance less or wash out compared to the background liver. Another feature that's important for diagnosing HCC is something called an enhancing capsule, which is a thin, bright rim around the tumor that can be seen on the portal venous or delayed phases. While it's important to look for, it can be kind of hard to see on CT and is often better seen on MRI. Let's take a look at another example of HCC. Here we are interested in characterizing a rounded mass in the right hepatic lobe. In this case, the mass is brighter than the rest of the liver during the arterial phase image, called arterial hyperenhancement. On the portal venous phase, or PVP, the mass is fainter and it enhances less and starts to blend in with the rest of the liver. But on the delayed phase image, taken between 120 and 180 seconds after IV contrast is given, the washout becomes more apparent. Notice how much darker the mass is compared to the rest of the liver, and it even has a thin, bright rim or enhancing capsule surrounding it. Therefore, when diagnosing HCC, the arterial, portal venous, and delayed phases provide essential information about arterial enhancement, washout, and an enhancing capsule that enables us to make the diagnosis with confidence.
Pros and cons. The pros. The safety results for cabozantinib were consistent with results from an early phase 2 study involving patients with hepatocellular carcinoma and with the known safety profile of cabozantinib. Treatment with cabozantinib, a tyrosine kinase inhibitor for target MET, VHGF receptors, and IHL resulted in longer overall survival and progression-free survival than placebo, and patients with previous treatment advanced hepatocellular carcinoma. Adverse events were consistent with the no safety profile of cabozantinib, and the rate of high-grade adverse event in the cabozantinib group was approximately twice than observed in the placebo group. The cons. Adverse events were managed with dose modification and support care. Dose reduction occurred in the majority of patients, and the rate of discontinuation due to adverse events for cabozantinib or placebo was 60%. The patient population included in this trial represents a small percent of patients with hepatocellular carcinoma, because the survival of patients who have hepatocellular carcinoma with child-proof liver disease of class B, of course, is determined by liver failure, and it may be impossible to discern any effect of treatment on the cancer. It is justified to exclude these patients for pivotal clinical trials. This is the most common effect adverse. Here the palmar-plantar erythroesthesia with patients who receive cabozantinib versus placebo. Application in Ecuador. In Ecuador, the SAO or Ecuadorian Society of Oncology present this analysis of COSMIC 331 study about cabozantinib in patient radioiodine refractory different thyroid cancer. Cabozantinib is a new drug, so the availability of this drug in Ecuador is zero. Now is that
Hepatocellular carcinoma, HCC, primarily arises in a cirrhotic liver, where chronic injury leads to repeated inflammation, fibrinogenesis, and disordered liver architecture. Cirrhotic livers exhibit focal lesions, areas of abnormal, immature hepatocytes that are predisposed to malignant transformation. Chronic viral infections, such as hepatitis B and C, also promote carcinogenesis through enhanced hepatocyte turnover and increased mutation rates. Hepatocellular carcinomas are phenotypically and genetically heterogeneous tumors driven by diverse molecular mechanisms. The identification of common genomic alterations has led to the development of targeted therapies that suppress hepatic carcinogenesis through multiple pathways. Multi-kinase inhibitors have been developed that simultaneously target key regulators in angiogenesis, tumorigenesis, and metastasis. Hepatocellular carcinoma is a hypervascular tumor. The initiation, growth, and metastasis of HCC relies on angiogenesis, the formation of new blood vessels from pre-existing vascular beds. Genetic changes and local hypoxia in tumors leads to the secretion of soluble angiogenic factors that activate resting endothelial cells in adjacent blood vessels. These angiogenic factors, such as vascular endothelial growth factor, are upregulated in most human tumors to help supply adequate oxygen and nutrients to the growing tumor. VEGF binds to the VEGF receptor, a tyrosine kinase receptor located on endothelial cells that promotes the activation, proliferation, and migration of these cells. Tumor-induced upregulation of VEGF is associated with increased tumor growth and poor prognosis. Several multi-kinase inhibitors have been developed that block the activity of VEGFR, preventing the formation of new blood vessels in tumors. Fibroblast growth factor is also upregulated in the majority of HCC cases. FGF and VEGF act synergistically to stimulate tumor-induced neovascularization. FGF has also been implicated in tumor cell proliferation, survival, and invasion. Inhibition of this signaling pathway induces apoptosis of HCC cells. Lenvatinib and regorafenib block the activity of the FGF receptor, decreasing tumor vascularization and proliferation. Another angiogenic factor, platelet-derived growth factor, is required for the recruitment of smooth muscle cells and paracytes that surround and support new blood vessels. Several multi-kinase inhibitors, including lenvatinib, sorafenib, and regorafenib, limit neovascularization by blocking the activity of the PDGF receptor. Multi-kinase inhibitors may also prevent tumor growth and proliferation by blocking the activity of several other tyrosine kinase receptors, such as KIT or RET. Activation of tyrosine kinase receptors initiates complex intracellular signaling pathways that promote cell growth, proliferation, survival, and differentiation. These receptors are often overexpressed or mutated in cancer cells. Tumor progression usually involves the action of multiple kinase pathways, and targeting several receptors simultaneously with multi-kinase inhibitors may provide a synergistic effect and reduce the possibility of drug resistance.
Conclusion. I'm a patient with previous treatment advanced hepatocellular carcinoma. Treatment with cabozantinib resulted in longer overall survival and progression-free survival than placebo. The rate of high-grade adverse events in the cabozantinib group was approximately twice than observed in the placebo group. That's all. Thank you for watching, and don't forget pick like and comment. Thank you.